Hi, everybody. Thank you so much for coming and listening to me present to you the findings that I have done my research on for the last couple months here at St. Vincent's. I'll be sharing with you an epidemiological insight to the demographics for addressing the rare phenotype of obesity genetic mutations in the Irish population. I will start off with an obesity introduction, going over the prevalence, classification, pathophysiology, genetics, and the treatment. So, according to National Institute of Health and World Health Organization, the definition of obesity is a chronic disease of abnormal fat accumulation of a BMI greater than or equal to 30, and it is presenting an enormous amount of health risks. Now, if we look over here at this trend line, this is why we should care, and this is why we should be worried, because statistics show that by 2030, approximately half of the US population will be obese, and by 2050, the male life expectancy rate will be decreased by 5 years. Continuing on of why this is a public health issue, well, we can look at a number of bodily health complications that arise as BMI also increases. We look at liver function decreasing, the risk of diabetes and even cancer happening, post-operative complications, including post-operative pneumonia and also deep vein thrombosis. We also see a constriction of muscle activity, which results in high blood pressure, high cholesterol, asthma, cardiovascular disease, sleep apnea, and coronary heart disease. We also see cartilage erosion around joints as you put on that weight, which also puts pressure onto your bones. This leads to osteoarthritis and gout. Continuing on to the 2 stages of classification of obesity. We have the King's Obesity Staging Criteria, which is a clinical scoring system that physicians use to treat and assess patients with obesity. This covers 9 domains: airway, BMI, CVC, diabetes, economic complications, functional limitations, gonadal dysfunction, perceived health status, and perceived body image. Now, the second classification, which is a little bit less common than the first one, but it can also treat and address patients of obesity according to medical symptoms, psychological evaluations, and physical functions. Now, I'll be explaining and describing the pathophysiology to you of patients with obesity, and these are included in the appetite hormone ghrelin, as well as satiety hormones PYY, GLP-1, and leptin. So before we have a meal, our ghrelin levels in our GI tract rise, and it goes up your vagus nerve into your satiety center in your brain, signaling, I am hungry, please feed me, I need energy to continue on throughout my day. Now, opposing to that signal, we have our leptin levels that come from the adipose tissue, your fat cells, up to your brain into the hypothalamus that say, I am satisfied, stop eating. Now, unfortunately, with obesity patients, we see leptin resistance. This is kind of thought as a knife. When you first buy one, it is really sharp. However, with overuse, it becomes dull. This can see as leptin resistance. With overuse of that signaling, the leptin signal to the brain becomes dull and weak and does not get that signal across efficiently. Now, we need to find how to get that signal across to stop excessive eating and the results of hyperphagia. This is what I just described in a visual representation. You can see before eating and after eating of the rise of ghrelin levels in the stomach and the lower levels of leptin from your adipose tissue. After eating and you're full and satisfied, you'll have a lower ghrelin level, increased leptin. And here we have a representation of the ghrelin coming from the gut up to the brain into the hypothalamus, saying that I am hungry and please feed me. On the other side, we have the fat cells signaling the leptin up to the brain saying stop. Now, this is the normal pathway for satiety homeostasis. We look at the genetic cause of obesity as well, and this is contributions of the MC4R melanocortin 4 receptor gene that regulates hunger and caloric intake. Now, patients with obesities have been found to have deficiencies in the POMC, PSK1, and the LEPR, which is insufficient activation of this MC4R receptor. Now, as I described in the previous slides, as the leptin resistance occurs in patients with obesity, we see the leptin secretion that starts the activation of this pathway does not get successfully turned over due to this breakage in the path. Therefore, we have found that research developed setmelanotide that acts on this MC4R receptor, binds to it, bypasses that whole POMC neuron, and acts on the LPR receptor, correcting that disruption in the pathway. This is a visual representation of that process that I just described. So here we start over with the adipose tissue, secretes the leptin, goes over here, binds with this leptin receptor, goes into the satiety center of the brain, the POMC that is encoded by the PCSK1. This travels along this pathway into this expressing neuron that gives us these results. We have a decrease in hunger, increase in energy expenditure, overall decrease in weight. Now, when that is not happening and something is broken, there's a deficient, there is something wrong with that pathway, we see the above, where it does not get attached to the leptin receptor and does not have these results. Therefore, we go an increase in hunger, increase in food take, hyperphagia in patients, excessive food seeking, decreased energy expenditure, overall increasing the patient's weight. Carrying on, this is the representation of the broken pathway. As you can see, the X marks not showing those sufficiently, but research has found the additive of setmelanotide MC4 agonist will start that activation and bypass this whole broken pathway. Looking over this, this shows a comparison between a healthy individual and the genetic obesity patient. As you can see, again, this is the broken pathway. Based off these deficiencies, a mutation would be present. So with the additive of the RM4 and 493 setmelanotide into this little breakage right here, that will solve the breakage in the pathway. So based off our results, we tested a panel of 100 participants and we scanned them for genetics and found that the most commonly present genes in these patients turned out to be EP300, RA1, SIM1, PHIP, and PCSK. Looking over now at the several ways to treat obesity, this is a future finding that, as I discussed before, the setmelanotide is the MC4 agonist that works on the POMC, PCSK1, and leptin deficiencies. Carrying on to the setmelanotide was found to be the key to that broken pathway. And those results were to reduce hunger, lower caloric intake, and increase energy expenditure. Now I will describe to you a common obesity treatment option. One of the three is lifestyle modifications. This includes dietary advice and activity. The second one including pharmacological intake, with several things that go into this category, but the two I will be discussing are the GLP-1s, Latitude and semaglutide. These are approved to treat general diabetes and act as appetite suppressants. Now, these GLP-1s carry along the brain-gut axis of the vagus nerve, blocking that hunger to stop the excessive food seeking. And the GLP-1 results in weight reduction, improved glycemic control, your HbA1c levels, as well as cholesterol and overall blood pressure. Now, if you look here, we have 4 symbols representing the 4 options of surgery. This would be bariatric surgery, aimed to treat patients of obesity with a BMI equal to or over 40. And we can see here, the first one is a gastric band. This is a silicone band placed around the lumen of the stomach, the upper portion of the stomach, that allows less food to come in. This reasoning allows for the patients to feel fuller on a smaller portion, as well as decrease your gastric emptying. Carrying on to the gastric bypass, you see that there's a cutout pouch up in the top part of the stomach, and there's actually a cut incision in your small intestines too that is brought up and attached to that small pouch to completely bypass the stomach. The duodenal switch is a combination of this sleeve gastrectomy that I will explain in a second, as well as the gastric bypass that completely bypasses the stomach. So this sleeve gastrectomy is a vertical incision cut here on the stomach, and this whole portion of the stomach is actually removed. This all leads to decrease in weight, decrease in food intake, and it really just slows the process of food going through your stomach. I will explain to you now the materials and methods that we used in this study. I will go over the study population, patient eligibility, and the data collection. If we look here, we have the participants, 30% males, and we have 70 females. 44 of those were positive and 56 turned out to be negative. This was an observational exploratory study, and the population we studied adult white Irish. So the eligibility criteria for these participants was body mass index equal to or above 40, early onset of obesities, so childhood obesity, and early onset hyperphagia. We look at the testing clinics and patient follow-up that were actually free of charge and were kindly provided by Pharmaceuticals Rhythm Company and Rare Obesity Advanced Diagnostics. Now, Rhythm Pharmaceuticals was the founder of setmelanotide. That was the founding key for that locked MC4R pathway. And we have Rare Obesity's Advanced Diagnostics, which is a program aimed to address awareness for obesity. All patients were given a written consent in this patient assessment. They went through questions such as failure to thrive before 2, thyroid conditions, prior anti-obesity medications, bariatric surgery if they had a failure or success with that operation, family history of obesity, genetic disease in any family member, and Bardet-Biedl syndrome. As we can see here, the data collection was taken by venous whole blood samples. We found this to be superior over a buccal sample that we also went along with some patients for, but we had gone through the venous sample classifying as negative, no variant, or positive variant detected. The positive results show detection in either A, at risk or likely pathogenic, a variant known as autosomal dominant or autosomal recessive, and lastly, they have a variant known to cause the disease in autosomal recessive exclusively. As we look here, the data collection continues on to be categorized as benign, likely pathogenic, or pathogenic. And a data analysis was done using IMB SPSS version 27 for our analyzing data. We used an unpaired two-tailed t-test, as well as tested all the categories of the negative and positive groups against a p-value of less than 0.05. Now I will explain to you the results and analysis of these results of the exam parameter hyperphagia, childhood obesity, BMI, and body weight. As we look here, we have two figures. The top one is a histogram and the bottom one is a pie chart explaining the hyperphagia results. We can see here the green represents the patients that tested positive for a genetic mutation, whereas the red represents the patients that tested negative for the genetic mutation. We see that 88% of our positive patients reported having hyperphagia, whereas 85% of our negative patients reported having hyperphagia. Now that is quite a high number for the negative patients having hyperphagia, so that leads me to the conclusion that hyperphagia does not suit us for diagnosing a patient with a genetic mutation. We look over at childhood obesity now, and we see that the 77% of patients that tested positive had the childhood obesity, and negative patients, 84% had childhood obesity. This is again a representation of the negative population having higher reports of childhood obesity, leading me to the question of what is controlling this childhood obesity. There must be some other gene, and what can it be, because these positive patients are actually resulting less than the negative patients. As we look over here to the BMI results, we have figure 7, the positive patients, figure 8 of the negative patients, and figure 6 over here is a comparison of the BMI of the positive and negative one in a histogram combined. As we see here, the bar charts are very closely aligned and similar in height. And so we see really no distinctive range that the BMI would suit for a positive testing patient for a genetic mutation. Over here, in table 9, you can see that I have laid out the average, median, standard deviation, and mode of both the positive group and the negative group for their BMI. Again, you can see that the median, the 52, 53, all those numbers are very closely together, showing no distinction between a strict and strategic range that a patient would fall in to be diagnosed as a genetic mutation participant. Figure 10 here shows a visual representation of that. As you see, the histogram has very closely lined up all together. This is a line chart now explaining the patient weight results. As you can see, again, the green is the positive patients, red is the negative, and they are pretty much almost on top of each other. So that also indicates that weight does not serve as a likely studied parameter to test if a patient is a positive genetic mutation. We can see here in a scatter plot representation of the heaviest BMI of compared positive and negative patients, as well as over here the negative patient and positive patient weight. Because I see no outliers on the scatter plot, it leads me to the question and think what else can be highlighted that represents the positive body mass index for a patient with genetic mutation, as well as weight and the BMI, because we are not seeing any conclusions based on this close comparison of the scatter plot. Over here, you can see that I have laid out a t-test using the testing against the p-value of 0.05. Both the p-values are actually 0.8 and 0.4, resulting in statistically insignificant results. And this is both for the BMI and the weight, as we've seen on this slide before. Carrying on into my discussion and conclusion, I will share with you what we have found, what research have found, and still what is unclear and searching for. We look into other trials that have found genetic mutations along with patients with obesity, and we have found that positive weight loss effects were 35% more significant in the POMC trial versus the LEPR trial, both on setmelanotide, and this was a study done over 10 European hospitals. We also have research has also found that the POMC in leptin receptor deficiency obesity treated with the setmelanotide daily reports reduction of hunger, as well as, interestingly enough, hyperpigmentation in the hair, skin, and nails. In conclusion, for my study in this project, we did the sample of 144, which came out to be positive genetic mutations, and 56, which were negative results. We tested this panel against the examined parameter of weight, BMI, hyperphagia, as well as childhood obesity, and we concluded that predicting a gene mutation is not likely using this parameter. So it leads us to the question, what else can be used to identify patients with positive genetic mutation, if there is any, to identify any demographics of these patients. And as well as insignificant results were found in the t-test that we used comparison of both groups with the p-value tested with 0.05. To conduct this study, I used the Master of Public Health Foundation competencies for Hawaii Pacific University by the Council of Education and Public Health. I demonstrated this first competency by recruiting patients in the surrounding Irish area to test them against a panel of 80 genes that can cause genetic mutation of obesity. For the second competency, I demonstrated this by using statistics and IMVs, SPSS. I used Excel spreadsheets to explain my data. And this also covers number 3 of the biostatistics, computer-based programming. The data collections, as I mentioned, was the venous whole blood samples that were found to be superior over buccal samples. I interpreted these results, data analysis for public health research that led me to thinking for our conclusion was not significant. So what else can we think of? What else can we find? What else can be statistically proven to see it for the demographics of somebody who tests positive for genetic mutation? Finally, design an original research study, including instrument development, sample selection, and analysis plan. I demonstrated this competency by doing this whole project of pulling in 100 participants in the remaining Irish area and testing them against this genetic panel of mutations. And I am just so grateful that you have been here to listen to this study. And now we are open for any questions.